We are going to discuss how we can make DCE-MRI in the abdomen better at 3 Teslas with the help of KT points. When you move to high field, you do that because you want a higher signal-to-noise ratio, but it also comes with a higher Raman frequency, which means a smaller B1 wavelength, and therefore you can have dielectric resonance in objects whose size comes close to the wavelength. At 3T, this is particularly true in the abdomen, where you often see zones of shade and loss of contrast. In some extreme cases, it can even look like that. Let us first present a reminder of what the principle of RF transmission with KT points is from a simple example. KT points are basically a fast alternation of short B1 and B0 gradient pulses, optimized to homogenize the spin excitation in an extended volume in spite of an inhomogeneous RF field. The following example shows the magnetization of two distant voxels M1 and M2, M1 being at isocenter, which we want to tilt by a flip angle FA of 90 degrees, although the applied B1 field amplitude has a dropping profile when moving away from isocenter, say drops by a factor 2 where the second voxel is. At first, let us transmit a B1 pulse along X, X, Y, Z being defined in the carrier frequency rotating frame. This will cause M1 to rotate by 90 degrees, while M2 will rotate by only 45 degrees. Then let us look at the action of a positive B0 gradient pulse or blip, just long enough to dephase M2 by 90 degrees, while M1 remain unchanged. Now let us transmit a B1 pulse along -Y so as to tilt M2 by another 45 degrees to bring it to the transverse plane, while M1 still remains unchanged as M1 and B1 are then collinear. At last, let us play a negative B0 gradient blip to rephase M2 in alignment with M1, still without affecting M1. So we managed to tilt M1 and M2 by the same flip angle, moreover with the same phase in this particular instance. The conclusion of this alternation of B1 and B0 gradient pulses is that the spatial variation of B1 has been compensated by the use of B0 gradients. This is the whole idea behind KT points, which are a mere representation of stationary locations where B1 subpulses are transmitted in K-space, gradient blips occurring in between to move from one location to the next. Depending on the three-dimensional B1 map of the region of interest, RF amplitude and phase are optimized at each KT point to reach an homogeneous excitation at the end of the sequence of subpulses. In parallel transmission, the plurality and geometrical distribution of independent transmission channels provides an increased amount of degrees of freedom to alleviate the optimization problem and raise the performance of the overall KT point RF pulse. This allows to design short pulses while keeping SAR within safety constraints. The following study made use of a dual transmission 3T Siemens system named Skyra. What we did was to take the standard liver examination that is used locally in our hospital and focus on the dynamic contrast enhanced protocol, DCE, a repetition of a sequence before and at several time points after injection of a gadolinium-based contrast agent that allows to follow the perfusion of tissues and characterize lesions. We chose this protocol because it is based on a 3D T1-weighted spoiled gradient echo sequence and is compatible with non-selective excitation, and our KT points are non-selective. Here is the diagram corresponding to a 3D spoiled GRE sequence. Let's focus on the radio frequency part. For non-selective excitation, you would normally use a hard pulse. And if you're lucky enough to have a 3 Tesla scanner equipped with parallel transmission, you have two different channels on which you can adjust the amplitude and phase of your square pulses to adapt to the patient in the magnet and minimize the dielectric resonance artifact by making interference patterns. This works most of the time, and that is what we call tailored static RF shimming. But since you don't have many degrees of freedom, sometimes you don't get a really homogeneous distribution of flip angles. Here on the map, the target was 11 degrees, which looks greenish, but there's mostly blue here, which denotes flip angles that are too small. And if you look at the red bar on the left, it shows a normalized root mean square error from the target of about 40%. The question is, how can we make it better? Can we obtain a more homogeneous flip angle distribution? Of course, we could use more transmit channels, 8, 16, 32, but that would be extremely expensive. What we propose instead is to keep the same hardware and just replace the hot pulse with the KT points that we introduced at the beginning of this presentation. On this example, on the left, you can see 7 subpulses in blue, interleaved with gradient blips in orange, which allow to move through the so-called transmit K-space between each subpulse, as you can see on the plot on the right. Now, the flip angle map obtained with this specific KT points pulse is a bit disappointing, as it is very similar to the one above. But don't worry, what you see here is just the initialization of our iterative optimization algorithm. Now we are going to witness the optimization process over 50 iterations. You see on the right panel that the flip angle distribution gets more and more homogeneous and gets closer to the target. And here we are. This is the pulse we are going to use for this patient with less than 15% inhomogeneity. Let's have a few more looks at the optimization process so you can see the pulse shape evolving and the transmit K-space trajectory changing in order to obtain an homogeneous flip angle distribution. Our goal was to compare the two techniques, the tailored static RF shimming and the tailored KT points, in routine operation conditions. We used a Siemens Magnetum Skyra 3T scanner equipped with 2-channel parallel transmission, and we acquired delta B0 and B1 plus maps on 50 consecutive patients. This allowed us to perform flip angle homogeneity simulations to compare the two pulse designs, just like on the previous slide. 20 of these patients received their DCE-MRI exam while a pulse designer was present, so we were able to design KT points on the fly and insert extra sequences before and at the end of the injection protocol with both pulses to assess the effect of each technique on image quality. Then 2 radiologists blindly graded image quality on a scale from 0 to 3 according to several criteria: liver signal homogeneity, T1 contrast quality, enhancement quality, structure details, and finally, a global confidence grade. Let's have a look at the results. Here, each point represents one of our 50 subjects. On the x-axis, you have the normalized root mean square error associated with static RF shimming, while the y-axis corresponds to KT points. And what you can see is that static RF shimming spans a much wider range than KT points. From that, you can deduce that our pulse design is robust, it works for all patients, and it can reduce drastically inter-subject variability. But what does it mean in terms of image quality? First, you can notice a cluster of subjects that show reasonably good behavior with both techniques. That's actually the typical situation. On the top row, we have image corresponding to static RF shimming for pre-injection, post-injection, and the enhancement ratio. And on the bottom row, we have the same for KT points. And there's not much to be said. The quality is really similar. Both techniques work well. However, for this kind of subjects here, the RF shimming is not really satisfactory. Here we have a 59-year-old male subject with ascites, and there is huge shading in anatomical images, and if you look at the enhancement ratio map, there is virtually nothing to see. However, when you use our KT points, you retrieve almost all of the image quality, which is particularly obvious on the enhancement ratio map. Finally, we gathered the results for image quality assessment for the 20 image patients. The grades obtained by KT points are higher for all criteria and significantly higher for most, especially in terms of global confidence. And if we define a good quality acquisition as one receiving a global confidence grade of at least 2 out of 3, only 55% of patients received a good examination with RF shimming compared to 85% with KT points. So in conclusion, patient-tailored static RF shimming works well most of the time, but for some patients, it is really not enough. If you use KT points, you can get rid of B1 shading artifacts in almost every situation, including ascites, and you would reduce inter-subject variability. Now we can expect applications to other 3D sequences in the protocol or to other anatomical regions. And one important thing is that KT points do not rely on parallel transmission. It helps, but it is not at the core of the technique. This means we could use KT points on any 3D scanner to reduce the B1 artifact. Thank you for your attention.